Today, we are going to get extremely personal. We're talking about the skin. But I don't mean skincare routines or anti-aging creams. We're talking about the skin as this massive, living billboard that broadcasts exactly what's happening inside our body.
It really is an incredible organ. I mean, it's our first line of defense against the world, but like you said, it's also our most visible early warning system.
Exactly. And specifically, we're looking at a bit of a medical paradox today. We're diving into a stack of material on dermatologic drug reactions and common skin conditions. It's a fascinating and honestly sometimes terrifying look at what happens when we try to fix the body with medicine and the skin basically rebels.
Which just says no.
Yeah. We take a pill to fix an infection and suddenly our skin is just shouting at us.
It is a spectrum, and I think that's the real challenge we're going to discuss. You take a medication to solve one problem, maybe a sinus infection, a seizure disorder, or high blood pressure, and boom, you have a new one.
And the challenge, which our source material really highlights, is telling the difference.
Exactly. Distinguishing between a nuisance, like a mild itchy rash, and a true medical emergency that requires, immediate transport to a burn unit.
That is our mission today. We're going to try to decode the language of the skin. We'll look at how the pathophysiology and the look, the clinical presentation.
Yeah.
We have a lot of ground to cover, from common diaper rash all the way to something called toxic epidermal necrolysis.
Which sounds exactly as bad as it is.
It really does.
It is severe, but understanding these mechanisms, I think, takes some of the fear out of it, or at least it replaces that fear with vigilance. It's about being a detective.
I love that. Skin detectives. Okay, let's unpack the landscape here. Our source material makes a very broad split right at the beginning. When we're talking about drug reactions, there are basically two big buckets, right?
Correct.
Okay.
Broadly speaking, you have irritant reactions and you have allergic reactions.
Mm-hmm.
The irritant side is usually more direct. Think of it as direct chemical damage. But the allergic side, that's where the immune system gets involved, and that's where things get incredibly complex.
And our text breaks that down even further.
It does. It breaks the allergic eruptions down into 4 main categories.
Okay, let's list them out so we have a roadmap before we really get into the weeds.
Sure. First, you have xanthomatosis. This is by far the most common. Think of a widespread red, blotchy rash.
Right.
Second, you have urticarial. That's your hives, your swelling, those itchy welts that can kind of move around.
Mm-hmm.
Third, and this is the severe end of the spectrum, is blistering.
Okay, that's where it gets scary.
That's where it gets very scary. And fourth, you have pustular, which looks a lot like acne or pus-filled bumps.
Okay, so picture this. You're a doctor or maybe just a concerned person and someone has a rash. How do you even begin to know which bucket you're in? The source material mentions this detective algorithm, specifically figure 16 to 1.
Yes.
It's basically a decision tree for, what, saving a life.
It really is, and it's a brilliant way to simplify a very complex diagnosis. It all hinges on a few visual cues, but there is one major systemic symptom that acts as the primary fork in the road.
Which is?
Fever.
Fever. That seems to be the big red flag here.
Yeah.
Why is fever the pivot point?
Because a fever tells you the reaction isn't just skin deep. It tells you the entire systemic immune system is activated and involved.
The whole body's in on it.
The whole body is in on it. So let's walk through the logic of that algorithm. Scenario A. You have a patient with a simple maculopapular eruption.
Okay, let's define that term because it comes up a lot. Maculopapular.
Right. So it's a combination of macule and papules. A macule is a flat red spot. You can't feel it if you close your eyes and run your finger over it.
Flat.
And a papule is a raised bump. You can feel that. So maculopapular is just a mix of the two. Red spots, red bumps.
Got it. So, scenario A.
I
have red spots and bumps, but crucially, no fever.
Right. No fever. Then you are likely dealing with a simple xanthomatous reaction. It's annoying, it's definitely itchy, but it's probably not life-threatening. The body is unhappy, but it's not in crisis mode.
Okay. But now, let's look at scenario B. You have fever present and you see pustules.
Pustules plus fever. Now, visually, this mimics an infection. You see pus, you feel heat, you think bacteria.
Yeah.
But in the context of a drug reaction, we have to think about AGP, acute generalized xanthomatous pustulosis.
That is a mouthful.
It is. But the key is that the presence of fever changes the game entirely. It tells us this is an acute, systemic inflammatory event, not just some pimples.
And then we have scenario C, the danger zone. Fever is present and you see blisters.
Blisters plus fever equals panic, or at least immediate high-level medical attention. This points us towards Stevens-Johnson syndrome or toxic epidermal necrolysis.
Wow.
When you see blisters in a drug reaction, it means the structural integrity of the skin is failing. This isn't just a rash. This is a systemic crisis where the skin is literally detaching from the body.
So the fever is really the body shouting that the reaction involves the whole system, not just the surface.
Precisely. And that brings us to the why, the pathophysiology. Why does this even happen? These aren't just accidents. This is T-cell activation. These are cytokines being released.
Can we break that down a bit? What is the body actually trying to do when it does this?
In most of these severe reactions, it's a case of mistaken identity. The drug enters your body, and your immune system, specifically the T cells, identifies the drug molecule as a threat. Maybe it thinks it's a virus,
Okay.
so it launches an all-out attack. The T cells release cytokines, which are chemical signals that basically say, destroy this area. Unfortunately, the area is your own skin.
So it's friendly fire, essentially.
Heavy, friendly fire. In some cases, it's direct toxicity where the drug acts like a poison to the cells, but very often it's your own immune system trying to fight the drug, and it causes this massive collateral damage to your own tissues.
That is a terrifying thought, that your own defense mechanism is what does the real damage.
It is.
Okay, let's get into the usual suspects. The source material breaks down specific drug reactions, and I want to go through these in detail because the timelines and the nuances are just fascinating. Let's start with the most common one you mentioned, maculopapular skin reactions.
Right. If you've ever had a reaction to an antibiotic, this is likely what you experienced. Presentation-wise, it's those erythematous macules and papules we just discussed.
Red flat spots and red bumpy spots.
Exactly. And they can be incredibly itchy. Pruritus is the medical term, and it can be severe. Now, the key here, and what I want listeners to really grasp, is the timeline. The source notes that these usually start 7 to 10 days after you start the drug.
That's a remarkably long delay. I think most people expect that if they're allergic, they pop a pill and explode in spots, 5 minutes later.
That's a huge misconception for this specific type of reaction. You have to remember, this is T-cell mediated. The immune system needs time to become sensitized.
What does that mean, sensitized?
It has to recognize the drug, decide it's an enemy, train the T cells to attack it, and then mobilize that army. That whole process takes about a week.
So you could essentially be finished with your course of antibiotics and then get the rash.
Yes, absolutely. And it creates a lot of confusion. Patients will say, but I stopped taking that yesterday, so it can't be the drug. But biologically, the timeline fits perfectly. It usually resolves about 7 to 14 days after you stop the drug.
And who are the main culprits here? The usual suspects.
The classics. Penicillins and cephalosporins, basically the beta-lactam antibiotics. Sulfonamides are huge triggers, and also some anticonvulsants.
Okay, so that's the standard rash. Annoying, but manageable. But then the text escalates, and it escalates quickly, to something called DRESS, drug hypersensitivity syndrome.
DRESS is a very, very serious condition. The acronym actually helps us remember what it is: drug rash with eosinophilia and systemic symptoms.
Let's unpack that acronym. Drug rash is obvious. What is eosinophilia?
Eosinophils are a specific type of white blood cell. Usually they're involved in fighting parasites or in allergies like asthma. In DRESS, their levels in the blood skyrocket. It's a sign of massive immune dysregulation.
And systemic symptoms. That sounds ominous.
It is. This is why it's so dangerous. It's not just skin deep. You have fever, you have swollen lymph nodes, we call lymphadenopathy, and you have multi-organ involvement.
Multi-organ, so it's attacking the internal organs too.
Yes. The liver, the kidneys, the heart, the lungs, even the brain. This is why I stressed the importance of fever earlier. If you have a rash and your lymph nodes are swollen and you're running a temperature, it's not just a rash.
It's a systemic crisis.
It could be fatal if not treated. The liver inflammation alone can be life-threatening.
And the timeline for DRESS is even slower than the standard rash, right?
Yes, and that makes it even harder to diagnose. It typically starts 1 to 4 weeks after starting the drug. It's a slow burn that suddenly ignites.
A month later. That's scary. You might not even connect the two.
Which is why taking a good history from the patient is so vital. If a doctor asks, have you started any new medications? People often only think of the last 24 hours. You have to think back a full month or even more.
And the drugs implicated here?
It's allopurinol, which is used for gout, sulfonamides again, dapsone, and a specific group of anticonvulsants like phenytoin and carbamazepine.
It seems like anticonvulsants are frequent flyers on this list of bad actors.
They are. Their metabolism in the body is complex, and it creates these byproducts that the immune system often misunderstands and attacks.
Now let's switch gears to the fast one. Urticaria and angioedema.
Hives. These are pruritic, which means itchy red raised wheals. And angioedema is the swelling of the deeper layers of skin and mucous membrane, so, lips, eyelids, tongue.
And the timeline here.
Fast, minutes to hours. This is the immediate reaction people usually think of when they think of an allergy.
The text mentions that drugs actually only cause about 5 to 10% of these cases. That surprised me.
It's a surprising statistic for many. If you break out in hives, it is statistically more likely to be caused by a viral infection, food, or even stress.
Huh.
But when drugs do cause it, and we're talking penicillins, aspirin, opioids, radiograph contrast media, it matters a lot because it can be the first sign of anaphylaxis.
Right. So if you see hives, you need to be watching the airway.
Absolutely.
Yeah.
If the hives come with difficulty breathing, throat swelling, or lightheadedness, that is an immediate emergency. Call for help.
Okay. Then there's serum sickness-like reactions. This sounds old-fashioned. What sets this apart?
It is old-fashioned in name. It comes from a time when we used to treat people with horse serum for infections. But today, it's a drug reaction. The key triad here is fever, rash, which is usually hives, and arthralgias.
Arthralgias.
Yeah.
That means joint pain.
Yes, intense joint pain. It mimics true serum sickness. It usually hits about 1 to 3 weeks post-drug initiation.
Yeah.
It's a complex reaction involving what we call immune complexes, these clumps of antibody and drug that get stuck in tissues and joints and cause inflammation.
Okay, now we get to my favorite one, just because it's so bizarre. Fixed drug eruptions.
The weird one, as you called it.
It really is. The source says this reaction recurs in the exact same spot every single time the drug is taken.
It's a fascinating phenomenon. Let's say you take a tetracycline antibiotic. A day or so later, you get a single red, raised, burning lesion on your arm. Just one spot.
Okay.
You stop the drug, it goes away over a week or two. 6 months later, you take that same drug again, and boom, that exact same spot on your arm flares up.
That is wild. It's like that patch of skin has a grudge.
It essentially does. The leading theory is that it's due to memory T cells that actually reside in that specific location of the skin. They don't circulate, they just sit there dormant, waiting for that trigger to return.
And the text says it leaves a mark, like a tattoo of the reaction.
Yes, it leaves behind hyperpigmented skin. So even when the redness and inflammation fade, you might have a dark brown or purple patch there for months or even years, reminding you of the reaction.
That is just. Biology is so strange. Okay, moving from the strange to the truly severe, we touched on this earlier, the danger zone. Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TNN.
These are the nightmares of dermatology. They are blistering eruptions. But when we say blister, please don't think of a blister you get from a new pair of shoes.
The description in the source is visceral. Generalized, tender, painful bullous formation and epidermal detachment.
Epidermal detachment is the key phrase. It means that the top layer of the skin, the epidermis, dies and sloughs off. It separates from the dermis below. The patient essentially looks and is treated like a severe burn victim.
And that leads to all these other complications like fluid loss, hypotension, electrolyte imbalance.
And secondary infections. Sepsis is a huge, huge risk here. The mortality rate can be quite high, especially for 10, which is defined by involving a larger surface area of the body, more than 30%.
So it's a spectrum.
It's a continuum. SJS is less than 10% of body surface area, but one can progress to the other.
And the culprits, is it the same list?
A very similar list to DRESS and others: sulfonamides, penicillins, anticonvulsants like lamotrigine, and NSAIDs.
It's sobering to think an over-the-counter NSAID like ibuprofen or naproxen could trigger that, however rarely.
It is rare, very rare, but it's why we respect these medications. They are potent chemicals, not candy.
Let's look at something a bit brighter, literally photosensitivity. Sun plus drugs.
This is a classic vacation ruiner. You're on an antibiotic, maybe for acne or UTI. You go to the beach for a day and you come back absolutely fried, way worse than a normal sunburn.
There's a distinction in the text here between phototoxic and photoallergic. I feel like people mix these up or use them interchangeably.
They do, but they're different mechanisms. Phototoxic is the most common. It is non-immunologic. Basically, the drug gets into your skin, absorbs UV light, and then releases that energy, which directly damages the skin cells.
So it's like an exaggerated sunburn.
Exactly. Drugs like amiodarone, tetracyclines, especially doxycycline and coal tar do this.
So if you are on doxycycline and you go in the sun, you're almost certainly going to burn.
The risk is very, very high. It depends on the dose and the sun intensity, but you should assume you will.
And photoallergic.
That's immunologic. The UV light from the sun actually alters the drug structure inside your skin, turning it into an antigen, a target that your immune system then attacks.
So it's a true allergy, just one that needs the sun to be activated.
Correct. Sulfonamides, thiazides, and NSAIDs are known for this. It's a delayed reaction, more like eczema or poison ivy.
And the clue is the location, right? That's
Yeah.
the giveaway.
Yes. It only happens on sun-exposed areas. The face, the V of the neck, the back of the hands, the forearms. But if you look under their watch band, no rash. Under the chin, no rash. It's a perfect negative image of where their clothing was.
That's a great detective clue. Finally, for this segment, let's talk about acneiform and pustular reactions.
Right. Acneiform means acne-like. Certain drugs, especially corticosteroids, lithium, and some hormones, can cause an eruption of pustules that looks like teenage acne.
How do you tell the difference?
Usually in a drug-induced acneiform eruption, all the lesions are at the same stage of development. They're all pustules, whereas regular acne has a mix of blackheads, whiteheads, cysts, all at once.
I see. And then there is AGP, acute generalized exanthematous pustulosis. We mentioned this in the algorithm at the beginning.
Right, and you want to contrast this with regular acne. AGEP has a very acute onset. It comes with a high fever, and it presents as diffuse redness covered in hundreds of tiny sterile pustules.
And then it peels.
Yes, after the pustules resolve, the skin peels, what we call desquamation. It's usually caused by antibiotics like beta-lactams or macrolides and sometimes calcium channel blockers.
So that covers the drug-induced landscape pretty well. But the source material also dives into common conditions that aren't necessarily triggered by a pill you swallowed, but are super relevant. Let's talk about contact dermatitis.
This is extremely common. You touch something, your skin reacts. But again, we have to split it into two main types: allergic, or ACD, and irritant, ICD.
Okay, what's the difference in the mechanism there?
Irritant contact dermatitis is simple physics and chemistry. You get a harsh chemical like bleach, detergents, or even just too much water and soap on your skin. It strips the natural oils, it directly damages the cells, and it causes burning or inflammation.
And it happens fast.
Very fast, within hours.
And allergic.
Allergic contact dermatitis is a true immune response. This is your classic poison ivy or a nickel allergy from jewelry. You touch the substance, your body identifies it as an enemy, and then, usually days later, you get the rash.
Days later. That delay seems to be a running theme with the immune system.
It is. It's a delayed type hypersensitivity, and that's why it's so tricky. You might wake up with a rash on your neck and completely forget you wore a new necklace 3 days ago, or you weeded the garden 2 days ago and now your legs are covered in itchy streaks.
The treatment distinction is interesting, too. The text says ACD responds better to topical corticosteroids than ICD does. Why is that?
Because ACD is immune-driven, so steroids, which are powerful immune suppressants, shut that inflammation down effectively. ICD is just direct physical damage. While steroids help a little with the inflammation, the main thing is to heal the skin barrier. So you use bland moisturizers and, most importantly, remove the irritant.
Makes sense. Moving on to a condition that every parent knows well, diaper dermatitis.
Diaper rash, it's a perfect storm in a small area. You have an inclusive environment, the diaper holds everything in, you have constant moisture, you have fecal contact, which contains enzymes that literally digest skin proteins.
Wow.
It just breaks down the skin barrier.
And then that leads to the complication, candida.
Yeast. Yeast loves warm, dark, moist places. A diaper is a tropical paradise for Candida albicans. If a diaper rash looks really angry and raw, with what we call confluent red plaques, big red patches, and little satellite pustules around the edges.
Satellite lesions.
Yes, little islands of rash away from the main continent. That's your clue that it's likely secondarily infected with Candida. It's not just irritation anymore, it's an active infection.
That's a great visual cue. Now let's talk about atopic dermatitis, or eczema. The source material has this really interesting breakdown of how it presents differently depending on how old you are. It's like the rash migrates as you grow up.
It does. Eczema is often called the itch that rashes. The mechanism is a mix of genetics. You are often born with a leaky, defective skin barrier and environmental triggers. But you're right, the location tells you the age of the patient.
Let's trace that timeline. Infancy. Where does it show up?
In babies, it's usually on the cheeks and chin, what we call the malar region, and this is key, the extensor surfaces of the arms and legs.
Extensor means the outer part, like the shins and the back of the forearms.
Exactly. And why? Because babies crawl. They rub those parts against the rug, the floor, The friction triggers the eczema flare.
And the source says it usually spares the diaper area.
Interestingly, yes, because the diaper actually keeps that skin moist and protected from scratching, so it's often the only clear skin on the baby.
That makes perfect sense.
Mhm.
Then we move into childhood.
As they get older and start walking, it moves to the flexual areas.
The creases.
The creases, the inside of the elbows, behind the knees, the neck, the wrists. The skin gets very dry, flaky, rough, and because kids scratch constantly, you start to see lichenification.
Lichenification, what's that?
It's a thickening of the skin. It starts to look leathery, and the normal skin lines become very prominent. It's the skin's way of trying to protect itself from the constant trauma of fingernails.
And then adulthood. Does it change again?
It does. It often becomes more diffuse. It can involve the face and hands heavily. The underlying redness, the erythema, is more prominent. Adults often get very dry, scaly, persistent patches on the eyelids or around the mouth.
So if you see a rash on the shins, think baby. Inside the elbow, think kid.
As a general rule of thumb, yes, it's a very helpful pattern to recognize.
Okay, we've diagnosed the problem. We've identified if it's a drug, the sun, or a diaper. Now let's open the toolkit. Segment 4, treatment and management. The source material has a golden rule for drug reactions.
It's simple, but it can be incredibly hard in practice. Discontinue the suspected drug immediately.
Why is it hard? Seems obvious.
Because sometimes that drug is keeping the patient alive. If you're treating a severe infection like meningitis or a cardiac arrhythmia or seizures, stopping that drug has its own major risks.
Right.
You have to weigh the risk of the drug reaction against the risk of the underlying disease. But if the skin is peeling off, if it's SJS or 10N, you have no choice. You stop the drug, period.
And you have to avoid cross-sensitizers too, right?
Yes, that's a key point. If you react to penicillin, don't just switch to amoxicillin. They are chemical cousins. You need to jump to a completely different class of drugs, maybe a fluoroquinolone or a macrolide.
For the symptoms, those are the itch, what do we do? It can be maddening.
Oral antihistamines are the go-to, and interestingly, the text suggests first-generation antihistamines.
Those are the ones that make you sleepy, right? Like Benadryl or hydroxyzine.
Exactly, and that's the point. The itch, the pruritus, is often worse at night when there are no other distractions. If you can sedate the patient slightly, they stop scratching in their sleep, which allows the skin to finally heal. It breaks that vicious itch-scratch cycle.
And oatmeal baths. That feels like an old home remedy.
It is, and it's a great one. It's soothing, it's anti-inflammatory. Colloidal oatmeal is a classic for a reason. It coats the skin and just calms the nerve endings down.
Now, the heavy hitters. Corticosteroids. This seems to be the mainstay for almost everything we've discussed.
It is the fire extinguisher for inflammation, but you have to be so careful. The text is very specific about matching the potency of the steroid to the location on the body. You cannot just use any tube of cream anywhere you want.
Break that down for us. Why does potency matter so much?
Well, you have low potency, medium, and high potency steroids. On the face, which has very thin skin, you should only ever use low potency, like hydrocortisone 1%.
What happens if you use a strong one on your face?
You can thin the skin permanently, cause broken blood vessels called telangiectasias, or even cause a rebound of steroid-induced acne or rosacea. It can be a disaster.
So face equals low potency, always. What about for the body?
For the trunk and arms, you can use a medium potency. For thick, lichenified lesions in adults, that leathery skin we talked about on the shins or wrists, you might use a high-potency steroid like clobetasol, but only for a short time. 1 to 2 weeks, max.
What about diaper dermatitis? I assume we aren't slapping high-dose steroids on a baby's bottom.
Absolutely not. The diaper area is occluded. It's covered by plastic, essentially. That occlusion increases the absorption of the steroid by 10 to 100 times. You could accidentally give that baby a systemic dose of steroids just by applying it to the skin.
So what is the strategy for diaper rash then?
The text mentions the ABCDEs: air, barrier, cleansing, diaper education, but mainly frequent changes. Let the area air dry. And zinc oxide.
The classic thick white paste.
It's a physical barrier. It blocks the feces and urine from ever touching the inflamed skin. It's like spackling a wall before you paint.
And if there's yeast?
If yeast is present, you use an antifungal cream, like an imidazole. First, let it absorb, then cover it with the barrier product. Low-potency hydrocortisone is used only for severe inflammation and only for a very short time.
And for eczema-atopic dermatitis, it's a long game, right? It's chronic.
It's chronic, so it's all about lifestyle management. Lukewarm baths, not hot. Hot water strips the natural oils from the skin, and you must moisturize immediately after bathing within 3 minutes to lock that water in. We call it soak and seal.
Short fingernails, too, I imagine, to limit the scratching damage.
Yes, and cotton clothing. Wool is often too irritating. Keeping cool is important too, since heat and sweat can trigger flares.
The source mentions steroid-sparing options. Why would we want to spare the steroids if they work so well?
Because of those side effects we just mentioned, skin thinning or atrophy. If you have eczema on your eyelids or neck, or if you are a child who needs treatment for years and years, you can't just use steroids forever.
So what are the alternatives?
We have the calcineurin inhibitors like tacrolimus or pimecrolimus. They are great because they inhibit the T-cell activation locally in the skin. They stop the inflammation without causing skin atrophy.
But there's a catch. The text mentions a black box warning.
There is. There is a theoretical risk of cancer, specifically lymphoma and skin cancer. This is based on animal studies with very high systemic doses. In practice, with topical use, it's considered quite safe, but patients need to be aware. It's a second-line treatment.
And they can sting.
Yes, a burning or stinging sensation is very common when you first start applying them, but it usually goes away after a week or so.
There's also mention of coal tar, which sounds industrial.
It is old school, it smells, it stains your clothes, it's messy, but it works. It reduces itching and inflammation. Sometimes the old ways stick around because they are effective, especially for very thick plaques of eczema.
Okay, finally, let's circle back to treating the truly severe cases, SJS and 10N. We said these are life-threatening. What can doctors actually do if the skin is detaching?
The treatment is primarily supportive care, and it's remarkably similar to treating a severe burn victim in a burn unit. You have to maintain their blood pressure with IV fluids because they're losing massive amounts of fluid through the damaged skin.
And control their electrolytes.
Yes, you have to balance electrolytes, manage their nutrition, and use broad-spectrum antibiotics to prevent sepsis because that skin barrier is gone.
What about IV, intravenous immunoglobulin?
Yes, IV is often used. It's a pooled antibody treatment from thousands of blood donors. The theory is that it floods the system and blocks the patient's own antibodies that are attacking the skin. It can help halt the progression of the disease.
And steroids, are they used here?
It's very controversial. The text says as much. Some centers think it helps to stop the immune reaction early on. Others believe it suppresses the immune system too much and dramatically increases the risk of a fatal infection.
So it's a judgment call.
A very difficult one. If they are used, it's a high dose initially, then a very rapid taper. But many burn units avoid them entirely. It's high-stakes medicine.
It sounds like a situation where every single decision is critical, and the margin for error is basically zero.
It is, absolutely.
So we've unpacked a lot today. We've gone from that fixed spot that flares up with a specific pill all the way to the systemic alarm bells of redress and SJS. We've looked at how to manage the itch that rashes in eczema and the importance of barrier protection in diaper dermatitis.
I think the big takeaway for me and for our listeners is that skin reactions are rarely random. We tend to dismiss rashes as just a rash, but they are specific biological responses to triggers, whether that's the sun, a new antibiotic, or a wet diaper. Diagnosis is all about taking a good history and recognizing the pattern.
It's about listening to what the billboard is saying.
Exactly.
So here's the part where I like to leave our listener with something to chew on. We talked about fixed drug eruptions, where the skin remembers the exact location to flare up every single time a drug is taken.
The local memory T cells, yeah.
It raises this really fascinating question about the localized memory of our immune system. We usually think of memory as being in the brain, or maybe immune memory as being in the blood, floating around the whole body.
Right, systemic.
But the idea that a specific patch of skin on your forearm can hold a grudge against a specific chemical for years, it completely changes how you think about your body. It's not just this uniform suit you wear. Every single patch has its own history.
It really does. It's a landscape with its own geography and its own memory.
So next time you see a spot, or an itch, or a rash, pay attention. Your skin is talking to you. Thanks for diving in with us.
Stay curious.